Now we are going to discuss diseases of the esophagus. The role of the esophagus is to serve as the passage for the food bolus between the oral cavity and the stomach. So it's basically just a tube for passage. The esophagus is not meant for storage of food for a long period of time. As we can see in the figure here, the bolus consistently moves down by the work of the muscle in the wall of the esophagus, and in most cases, gravity also helps with moving the food down as well. The first condition we will talk about related to the esophagus is gastroesophageal reflux disease, also known as GERD. This term is probably more well known to the public. If we look at the name of the disease, gastro, which is something from the stomach, and we have esophageal from the esophagus. So this is reflux between the stomach and the esophagus. As we mentioned in the previous slide, the food bolus moves down the esophagus and into the stomach. If everything is normal, the gastric contents should move down into the duodenum and into the remaining lower GI tract. However, in this disease, there is reflux, meaning that the gastric contents from the stomach moves back up into the esophagus, and this causes damage. We know that the gastric contents are acidic because of the gastric acid. But in the stomach, we have protection against acidity, so under normal conditions, epithelial cells, which protect and secrete a bicarbonate-rich solution that coats the mucosa to protect our stomach. However, this is not the case for the tissue in the esophagus. Remember, we just mentioned that the esophagus' normal function is to serve as a passage for the food bolus rather than to sustain the acidity or long-term storage or the processing of food. Therefore, in this case, once the gastric content flows back up into the esophagus, the acidity will damage the lining of the esophagus because that part of the body is not equipped to deal with the low pH, the high acidity content. GERD affects more than 20 million Americans, so it's a very common disease. And the condition is usually caused by the incompetence of the lower esophageal sphincter, or LES. And this sphincter functions to control the entry of the food bolus from the esophagus into the stomach. If it is working properly, things should not be able to flow back up. But if it is loosened for one reason or another, then reflux can occur. People suffering from GERD usually complain about heartburn and belching, and sometimes even dysphagia, among other things, which we'll talk about later on. These are very typical signs and symptoms for this condition. To medically diagnose GERD, we need to assess that these symptoms are there, and if the individual gets relief after being given a proton pump inhibitor. If we think about the pathophysiology, the damage to the esophagus tissue is done by the gastric acid. So if we can reduce the acidity, that should help with the symptoms. So if we have these symptoms, and if these symptoms improve when given a proton pump inhibitor, this would allow for the diagnosis of GERD, and we can tell that there is reflux occurring. To treat GERD, our goal is to address the lower esophageal sphincter and make it competent again. Then this would help since it is the root cause. Also, as we mentioned as a diagnostic therapy strategy, we can use it as a regular treatment to decrease acid secretion. So we see that here. We can also use other therapies to protect the mucosa of the esophagus. This would be more passive because we are not dealing with the root cause. In essence, we are just adding a shield. We're not stopping the bullet. There are also medications we can use that we'll go in detail in a minute. And we can also do lifestyle modifications, including modification of the diet. In some cases, we may also need surgical interventions. This book has, your textbook has figures of the different surgeries that can be done to treat GERD. If we look at this figure here of the stomach, this arching dome up here is called the fundus. And this part of the stomach is usually empty because we can see the entrance here of the food of the esophagus is lower than this part up here. So this part's usually filled up with air, and we would not want it to fill completely with food and liquid. So the surgery would wrap this part of the stomach around here where the esophagus and stomach meet to strengthen the LES or lower esophageal sphincter. This should help with the muscle control in this area and make the sphincter more competent. Here are some medications that we can use to treat GERD. For example, we can reduce the secretion of acid, or we can also use an agent that works again against the already secreted protons. We can also use foaming agents to protect the mucosa of the esophagus. We already mentioned the proton pump inhibitors that are used as a diagnostic agent to treat and see if the symptoms are reduced. So we already mentioned the signs and symptoms and what is likely the cause of GERD. The nutrition assessment of GERD is part of the assessment for all upper GI diseases. Whether it's oral cavity disease or stomach disease, the assessments are similar. Please review this in the book for what questions need to be asked and what needs to be assessed. Box 14.3 has this in more detail in your textbook. For nutrition diagnosis, many people who are overweight or suffer from obesity may have GERD. There is a positive correlation between the conditions. With the damage done to the esophagus, there might also be inadequate intake. And also, since GERD can be painful, it may cause reluctance in swallowing. We can also say that there's altered GI function, since if you think about it, the sphincter is not functioning correctly. We've already discussed some of the nutrition interventions like reducing gastric acidity and changing the eating strategy to smaller, more frequent meals. Another important intervention is to have the patient do a trial and elimination routine. This allows the patient to be conscious and observe what food or beverage items are associated with their GERD symptoms. Once identified, they can exclude those items from their diet. So for example, a common food item that precipitates GERD symptoms is coffee, because in regular coffee we have the caffeine, and caffeine is known to loosen the LES. It makes the sphincter muscle more incompetent. If this is the case for a patient, we will have to limit caffeine or totally eliminate their regular coffee intake. And then for monitoring and evaluation, it is going to be a constant struggle for the patient. They have to really assess the effectiveness of all of these interventions. Usually they will be taking medication and paying close attention to what they're eating, the dietary component. Here we have some suggested nutrition interventions for GERD. For some people, what they eat can really affect the LES competence, which is associated with the worsening symptoms. For example, there are foods that are affecting the root cause that cause the LES to relax. Pay attention here also for the foods that may increase gastric acid secretion. Obviously, when the gastric acid contents are more acidic, the reflux will cause more damage if not controlled. And if we look here at coffee and then also alcohol, we see that they fall under both of these two categories. So they not only cause the loosening of the sphincter muscle, but also increase the gastric acidity. Therefore, these are the ones that we really want the patient to stay away from. Associated with GERD is a condition called Barrett's esophagus. GERD is a chronic condition, and when the reflux occurs, there is damage to the esophagus, and so the body undergoes a repair process. But then the next reflux comes, and there is damage again, and then repair again in that same location. This repeated pattern of damage, repair, eventually will lead to a change in the epithelial cells of the esophagus mucosa to the point where the cells no longer appear like the normal esophageal cells that were there before the GERD took place. This is a condition we call metaplasia. So we can see here, meta means change. So this indicates that the cell type is changing. If we review Chapter 9 on cellular response to injury, metaplasia is one of the responses. Remember that we had hyperplasia, hypertrophy, and now also metaplasia. Unfortunately, this type of response is a precursor to cancer. If we don't control GERD effectively, the lower esophagus is at risk for the development of cancer, so this can be very serious. The change in cell type is confirmed by an endoscopy, where we may have to take a biopsy to determine that it is indeed a different type of cell. Although we may be able to visually see in the gross anatomy that the color of the Barrett's esophagus is different than the mid or upper section of the esophagus. And that's what we see in this figure here. This whole area here with the really dark red is different than out here where we have the normal epithelial cells. So Barrett's esophagus would be considered a complication of GERD. So if we are successfully treating GERD, we should be able to better prevent this condition from occurring. Dysphagia literally means difficulty swallowing. Many diseases can cause this condition, and usually in clinical settings, we will see it with patients that have different levels of dysphagia, and it could be associated with weight loss, malnutrition. In certain cases, like for dementia or stroke patients or other types of brain injury, the damage to the nervous system causes a malfunction of the muscles involved in ingesting. In adults, when we normally ingest, our airway closes, but with those conditions I just mentioned, the coordination of those muscles is impaired and the airway may still be open when we are trying to swallow. This could lead to food or beverage getting into our airway, leading to aspiration. And aspiration can be unpleasant, and also it can be dangerous because if the food or beverage gets down into our lungs, it can cause pneumonia. Also, some of these patients may not have a cough reflex due to their condition, and this type of pneumonia can be fatal. To diagnose dysphagia, we need help from SLP, the speech language pathologist. They will perform a swallowing assessment barium study. So they will change the consistency of the barium paste and watch through X-ray what is happening when the patient swallows, and then they can also tell which part of the muscle is impaired, and they'll also look for where the barium goes. Is it going down the esophagus, or is some of it getting into the airway? During your clinical rotations, I would highly recommend asking if you can observe this being done. It will help us to better understand not only the anatomy of that part of the body, but also what exactly is going on with swallowing difficulties. So here's a list of the main diseases associated with dysphagia. It could be a neurological disease, for example, a stroke or closed head injury, and we will see many of these survivors do have dysphagia. It could also be a chronic neurological disorder. For example, we'll see it in some types of dementia, such as Alzheimer's. It could also be a muscle disorder. Swallowing is a process that involves the coordination of many muscles in the head and neck area. Therefore, if we have a muscle disorder, we can have dysphagia. We also mentioned GERD, and if we think about it, the mucosa of the esophagus is damaged by the acid in this condition. So when anything like food travels through, it causes pain, which may make it difficult for patients to swallow. Here we also see achalasia in bold. This is where the LES does not relax when swallowing, making it difficult to pass food through to the stomach. It is often caused by damage to the esophageal nerves. We also have malignancies, things like throat cancer or esophageal cancer, which could block the passage, and this could cause dysphagia. In this case, the dysphagia would progress, becoming worse and worse over time. So this is something we would want to pay attention to if someone is complaining about the progressive swallowing difficulty over the last 6 months. Then we need to check if this person is developing some type of head or neck cancer. And there are a couple of other things that can also cause dysphagia, such as getting it with post-intubation, which we will talk about more when we discuss critical illness. So nutrition therapy for dysphagia, we have the National Dysphagia Diets 1, 2, 3. These are very clear and specific guidelines for each of these diets that we would follow based on the diagnosis by the SLP and what type of the diet the patient can tolerate. So, and monitoring and evaluation is pretty self-evident here. This table summarizes the National Dysphagia Diets 1, 2, and 3. Under each category, we see food allowed as well as food not allowed. So we should be well aware of which foods fall under each category for the specific diets. And depending on the diagnosis, again with help from the SLP, we should be able to determine which diet is most appropriate. After the SLP conducts the assessment, their recommendation will be very clear. The SLP will likely document in their notes the suggested diet with the certain appropriate consistency and texture, and they will even note it for the consistency of or thickness of the liquids. So we need to be sure to pay attention to our colleagues and read their notes. Hiatal hernia is another condition that has similar symptoms to GERD. What happens here, if we look over here at this figure, under normal conditions, we have the diaphragm, and the whole stomach should be below the diaphragm within the abdominal cavity, while the esophagus is up in the thoracic cavity. When something happens, such as heavy lifting, violent coughing or sneezing, or even vomiting, this can cause the upper portion of the stomach to protrude through the esophageal hiatus in the thoracic cavity. So this part moves up. And so then the diaphragm here becomes a ring-like structure and restricts the movement of contents within the stomach. So it now looks almost like we have an hourglass here, or a dumbbell, if you will, with two large ends and then a thin bar through the middle. And as you can imagine, this would cause various symptoms. So depending if it is sliding or rolling, we call it a type 1 or type 2 hernia. Most, about 95%, are sliding hernias. And again, this is where the LES protrudes above the diaphragm. So that's up here, along with the stomach, this portion. Then the remaining 5% are the rolling type, where we see the LES remains stationary, but the stomach protrudes above the diaphragm. And incidence of this condition increases with age. The symptoms are similar to GERD, such as belching and even dysphagia in some cases. Therefore, the intervention is similar to GERD as well. We want to control gastric acidity and eliminate the food items associated with the worsening symptoms. But because it is an anatomy issue, there are some that may require surgical repair.